and gentlemen, welcome to day 3 here on the M42 main stage. This is the inaugural Abu Dhabi Global Healthcare Week, and I'm sure you'll all agree it's been a fabulous few days here, but the action doesn't stop now. We've got a full day of action planned here on our M42 main stage, from inspirational talks to special presentations and amazing thought-provoking panel discussions. And that's what we're going to kick off today with right now. We are exploring proteomics pioneers shaping the future of healthcare research in the UAE. And to take us through this, I am delighted to welcome on stage an expert moderator. I'm going to consider her my co-host for the morning, Dr. Shalini Behel, who is the R&D scientist at M42. Please give her a big round of applause. Thank you so much, Dr. Shalini, and we have a wonderful cast list with us today, don't we? So let's welcome on board your special guests. We have Dr. Abdullah Mahboob, who is Assistant Professor, Department of Chemistry at the U.A.E. University. Please welcome on board Dr. Abdullah. Dr. Stephanie D'Souza, who's a postdoctoral research fellow at the Mohammed bin Rashid University. Dr. Stephanie, please come. Dr. Nelson da Cruz Suarez, the Assistant Professor, College of Pharmacy at the University of Sharjah. And that completes our cast list. Over to you, Dr. Shalini.
So, good morning, everyone. And I thank everybody for joining us on this session today. The capability to sequence genomes today has certainly increased our understanding of the disease. However, proteins seem to provide more knowledge about how these markers function within the cell than any other large-scale capabilities like genomics or transcriptomics. So with this in mind, and also to increase our capabilities of multi-omics, we decided to venture into not only genomics but also proteomics. And to boost research into this area, we decided to, and announced the competition for a grant competition for proteomics at the Arab Health Week earlier this year. And we have 3 winners with us. Initially, the competition was announced for 1 winner, but the proposals were so compelling that we actually decided to choose 3. This is only a reflection of the growing research within this area, and we would like to hear more about how we can use proteomics to boost our existing capabilities and existing researches in this field. Over to Dr. Abdullah for his work.
Hello, everyone. I hope you can hear me well. So we work on autism spectrum disorder, and we work in sort of 2 different areas simultaneously. We are looking at ways of diagnosing autism spectrum disorder with blood tests as opposed to just the usual methods used currently. But we also are working on the development of novel treatments for autism spectrum disorder. The key here is that we have a mouse model that we recently discovered resembles some of the chemistry, the protein chemistry that exists in children with ASD. And so manipulating those protein levels in the mouse, we're able to see the progress in the mice model. So the mice are actually, they can actually be scored on an autism spectrum disorder scale, and we can see with treatments that they're improving, and we can correlate that to the protein levels. But what we're really interested in doing with the M42 grant is to look at that in the blood samples of children with ASD and try to see if we can correlate the severity of the condition with certain protein levels that exist in the blood samples.
Thank you very much. Dr. Nelson, would you please highlight your research?
Thank you so much. It's a pleasure to be here. We're applying proteomics and metabolomics for the search of biomarkers. Biomarkers, people they associated with diagnostics, which is right so, but we are far beyond that. We're using biomarkers to predict the severity of the disease, predict treatment, how the patients they will respond to treatment. We use biomarkers to see if there is any resistance to drug. Basically, it's another way to do precision medicine. So we are transforming, as we speak, the way we treat our patients. So I look forward for the debate. Thank you so much.
Thank you. Dr. Stephanie, please highlight about your research and how do you think proteomics would add value to the work that you are currently doing?
Thank you, Dr. Shalini, and thank you, everyone, for this opportunity. So I work at M42, and the main focus of my research is subtyping of type 2 diabetes patients into their clinical based on their clinical pathophysiologies. And we were successfully able to classify type 2 diabetic patients, especially the Emirati population, into 5 distinct clusters. So, and we did this with 2 types of databases. One is the people who had long-term diabetes, which is approximately 14 years on an average, with 2 or more clinical complications, diabetes-associated complications. And also, we were able to reproduce the same kind of result in patients without complications and who were newly diagnosed, which is approximately 2 to 3 years of diabetes. Now, what we are doing is not just restricting ourselves to the phenotypic clustering, but also we are moving forward into identifying the genetic markers specific to these subtypes so that we can classify these patients or diagnose these patients right from the beginning, look at their risk of developing complications in the future, and also so that they can get targeted therapies. With proteomics, what we are doing is we are trying to take it one notch higher. Now we know type 2 diabetes is a metabolic disease, so genetics alone will only explain 16% of the heritability. So the remaining is attributed by the environmental factors, the diet, and all this can be evaluated based on their proteomic profile. So we are taking blood samples from the patients, and we are looking at their circulating proteomic profiles and classifying them based on their clinical pathophysiologies. Now, how will this add to our research is, I believe proteomics is the way forward. So like I already mentioned, genetics can only explain 16% of the heritability of the known common variants, and only 1% of the rare variants can explain the heritability of type 2 diabetes. So the major player in explaining this variation among patients is proteomics, is what I believe. And I believe subtyping based on proteomics is going to help us identify more biomarkers and more precise biomarkers for the classification of the patients. Thank you.
Yeah, thank you. This is very interesting. But while you are planning to integrate proteomics into the current clinical settings for precision diabetes, how do you think that this would be implemented? And do you see any barriers to this?
I do see certain concerns, not with respect to the technology itself, but the implementation of it.
Yeah,
So
with
majorly,
with
yes.
the current clinical settings.
Yes, so the current clinical settings focus more on identifying type 2 diabetes and not subtyping them. So it is believed that diabetes is one multifactorial disease, but majority of the clinicians do not try to identify the major reason underlying. So is it because of the insulin deficiency? Is it because their beta cell dysfunction? Or is it purely based on age and various other comorbidities are giving the pathophysiology of this type 2 diabetes? So this is not extensively analyzed in the clinical setting. And what I believe is, if we come up with a biomarker panel, so for example, we have specific ranges for insulin levels. Along with certain the variants which are associated with these markers, and also their proteomic profile, then we can develop this as a diagnostic panel and give it to the clinicians, and so that they can identify the exact subtype of the type 2 diabetes, and they will be able to treat the patient better rather than just giving them, starting off with the metformin for any sort of disease. I believe they can directly target the cause for the type 2 diabetes.
Wonderful. While we already believe that type 2 diabetes is a well-managed disease, moving on to technologies like proteomics and integrating new biomarker discovery with specified new panels, I'm sure this proteomic profiling will change the landscape of diabetes in future,
I hope so.
specifically for the Emirati population. Uh, Dr. Nelson, you have mentioned that you would be looking at the discovery of new biomarkers as well for prostate cancer. So how do you think this would impact the current screening practices within U.A.E?
Correct. So let me just go a step back. When talking about biomarkers, most of the biomarkers that we use today, they were found, identified in the Western population and validated in the Western population, meaning by Western, European, and North American. So those biomarkers, they're still a question mark. We don't know how they validate or the predicted value when we're looking at other populations with a different background, such as our region. So what we intend to do, and specifically when you're talking about prostate cancer, the PSA, for instance, Emiratis patients suffering from, not from cancer, but from inflammation of the prostate, they have high levels of PSA. So which means that whatever levels of PSA that they have, it doesn't have any predictive value. So we need to go for the biomarkers, other biomarkers that are unique to these patients, and actually that we can use it not only to, again, to diagnose the disease, but to manage the disease. And this is an important point, because at some point we have to move from the traditional medicine, which is one cut fits all, and what we are moving is to more precise medicine. So we want to transform. And just on the side note, we have, I started the proteomics, and I'll be very in the 2 minutes. I started proteomics with the 2D gels. I think was 25 years ago, something like that. Right now, what we are having, it's an amazing opportunity to actually use some of the platforms like the SomaLogic and combine with artificial intelligence and look at those biomarkers to predict, first of all, personalized treatment and hopefully prevent the disease. So this is our goal for the future. Thank you.
Very nice. How do you think that, what would be the necessary steps if you want to include them into the current diagnostic practices?
Yeah, I mean, again, so we must go and revisit the biomarkers that are out there, not only for prostate cancer, breast cancer as well, and then just to see so we have to revisit a cohort based on the Emirati population, first of all, and then see what else, which biomarkers, which proteins that actually correlate or are associated with the disease. And then the other point is, whenever the patients they go under treatment, we need to follow the treatment. Can we predict the response to treatment? So I think this I think will be the next level of proteomics, the way we do it, and precision medicine.
Yeah, would you like to highlight some of the preliminary work that you have already done?
Thank you. Yes, so that's a fantastic point, because I was in South Africa, and actually, when you look at the biomarkers for prostate cancer in African males, obviously, it's very different from what we see biomarkers in European population, mainly because it's the other end. So they tend to suffer from much more aggressive prostate cancer. So if you were to diagnose the prostate cancer in black Africans, then we need to look yet for another biomarker. So it's a point where the background, ethnic background, does matter. So I think that as I said, so I think that we have to look out after our own problems, find out our own solutions, but let's not forget what the others have done for us. So it's kind of, we want to translate that to a new reality. Thank you.
Thank you. I think this is very important that most of the researches that have been done so far have been either done on Western or Caucasian population or African population, as mentioned specifically for prostate cancer. But we need to explore the Arab ethnicity to have our own biomarkers and develop diagnostic panels. Thank you very much. Dr. Abdullah, you had mentioned about the role of interleukins within your research. How do you think that these interleukins play a role? Specifically, we would like to talk about interleukin 38 here.
Yeah, so interleukins are a very fascinating group of proteins. They are involved in communication, and they seem to pop up in many, many different kinds of conditions. And our understanding of them and how they affect things like brain development in the case of autism spectrum disorder, and they're also involved in things like heart disease, for example, as well. It's very poor at the moment. And one of the problems is that it isn't like it's just one interleukin going up or going down. That's not as simple as that. Like if you have a decreased interleukin 38, you have this problem. If you have an increased one, you have that problem. They're constantly talking to each other. So interleukin 38, for example, lowers the levels of interleukin 1 beta and interleukin 6. And that, in fact, our research started with corona, not even with ASD. And that was actually involved in the mechanism that coronavirus uses to cause what they call the cytokine storm, which causes poor prognosis in patients. In the case of ASD, it seems that these interleukins are constantly communicating in the blood samples, in the blood itself, as well as within specific regions of the brain. So, in the case of the blood, interleukin 38 actually seems to be increased in children with ASD, but in the case of specific regions of the brain, it is decreased. And in both cases, it seems to cause an inflammatory response that we associate with some of the characteristics of developing ASD. And so another thing I think which is keeping with the theme that we just discussed, these levels have only been measured in Western populations. And we already know, in fact, from some studies that were done in Saudi Arabia on a much more limited number of proteins, that the Arab population, when it comes to ASD, have a very, very different profile when it comes to the protein levels that they have that are associated with severity. And so what we're looking for is to see if IL-38 or things that communicate with IL-38 in the blood are associated with that. The reason that this is very exciting for us is because, you see, we already have a mouse model in which we discovered that IL-38 is deficient in the exact same areas and in the exact same manner that it is in children with ASD. And we already have a way of delivering this protein to the mice. And so we're able to do not only diagnosis, but also test potential treatments against autism spectrum disorder.
Yeah, thank you. So while proteomics is relatively new, you have already been working on mice models for identification and characterization of such proteins. How do you do it routinely as of now, before proteomics?
Okay, so this is actually where the grant is extremely useful for us. If we want to look, whether mice or humans, at levels of cytokines or let's be specific, of interleukins, we would have to do ELISA, and that's if you're doing that on 20 proteins, okay, on 30 maybe, but then the thing is we are trying to look for the markers, so it doesn't make sense for us to just test every single possible protein we can buy an ELISA for. Not only is that extremely cost prohibitive, but it's also very time consuming. With the new techniques, we're able to screen up to 7,000 proteins at once and then look at controls versus children with ASD and also correlate that to severity. So that's where proteomics is extremely powerful for us. In the mice model, so SomaLogic doesn't really apply to mice. It mostly applies to human markers. But in the mice, we are able to then take whatever we get out of the human data and try to see if it correlates in the mice model. We already know that specifically for IL-38, it is correlated. So in children with ASD, the levels of IL-38 are correlated to the ones in the mouse. And why is this useful? Because in the end, we're able to test new treatments on mice. And it also gives us a very important question of how relevant are animal models for human diseases. This is a big question in biomedical research. We tend to use mice and rabbits and rats, but there's always a question of how relevant are they for specifically testing new treatments. Sometimes they might not be, but we actually believe that in the case of autism spectrum disorder, they might actually be quite relevant subjects.
Good. So while we already know that autism, there is a high rate of prevalence here in UAE. So I'm glad to know that we are moving into pediatric diagnostics with this research moving ahead. Dr. Nelson, would you highlight more on your work with genomics, and while you also do proteomics, how would you plan to expand your work?
Yeah, I mean, very rapid. I cannot think of research without proteomics because I've been doing proteomics for the last 30 years. For the most young generation, for my students, normally I get the question, why proteomics if we have genomics? Well, you have sometimes nothing is wrong with the gene, nothing is wrong with the way the gene is transcribed, and still you have a disease. Proteomics matters. So as if you have a factory and you have a map of the workers that's supposed to be on that day, but you still need to go if actually the workers are there. So if the proteins are doing what they are supposed to do and understand the mechanism of the disease. So it's not just genomics, it's not transcriptomics, it's proteomics, it's metabolomics, it's beyond that, it's all together, and will take us to the next level. So it's exciting times to be here, actually.
For sure. I do believe this is a multi-omics era. Dr. Stephanie, you already have genomics data with you, and now you would be venturing into proteomics. Do you think that while you are doing the subtyping of the type 2 diabetes, you would want to apply this to AI algorithms and like have clinical implication here?
Yes, absolutely. In fact, we're already doing that. So the first step that we did in subtyping is the phenotypic clustering. And we started off with traditional statistical methods, the k-means clustering, the hierarchical clustering. But very recently, just at the end of last year, we started using one of the software from IBM, the modeler, which integrates AI technology into it. So this, rather than telling the software or the tool to give me divide my data into specific clusters, which is the k-means method, we are letting the AI determine itself just based on the entire database. So which our database includes at least 140 different parameters. Which includes, medications, the complications, their general laboratory demographics, age, BMI, family history, their smoking history, drinking history, everything. So we give all these parameters as input, and the software itself decides how many clusters can it classify this data into. So yes, absolutely, AI is helping us with phenotypic clustering. And now we intend to correlate this data, the phenotypic clustering data, along with the genotypic and the proteomic data using more machine learning algorithms.
Very good.
Yes,
so
the project is
how
in
many
progress.
clusters would you plan to identify here using all of this data that you've generated?
So far, like I already mentioned, based on the newly diagnosed patients, based on long-term diabetic patients, based on the patients with complications and without absolutely no complications, we were able to identify 5 clusters. So 4 of these are in consensus with the clusters which are identified in the Caucasian population, which is severe insulin. 2 forms are in severe, which is insulin deficient, and one with beta cell dysfunction. 2 are mild. One is obesity related, which is a major proportion of the Emirati population, and the other one is age related, where people tend to attain diabetes later in their life, post 60 years, and because they're diagnosed with diabetes later, again, the severity of their complications is very low. Now, the 5th type, which we identified, is mild early onset diabetes cluster. So these are the patients who attain diabetes, type 2 diabetes specifically, very early in life. So as early as 28, 20, we have patients diagnosed with type 2 diabetes as early as 28, 29 years, and the cluster contains maximum of 40 years of age. So these patients, again, they have very severe form. The age is the main factor which groups them into this cluster, but their secondary pathophysiology is either the insulin deficiency or beta cell dysfunction here in case. Now, this particular cluster is very specific to the South Asian populations. It has never been identified in Caucasian population or any other population, except for one Korean population and one Indian population. So I believe this is very specific to our region, the Southeast Asia, and also very specific to Middle Eastern population also. So we would like to, explore more on this cluster again with the Emirati population.
Very good. Thank you for sharing your wonderful insights with us. And while we can keep talking and knowing more about your research, we do have a certain time frame in mind. And I would like to close this session with a big round of applause to all our grant winners here.
Thank you.
Thank you. Thank you all.
Thank you. We're going to get a group photograph. Such a wonderfully insightful panel to kick off day 3 for us. I'll just move out of the way. Thank you once again, and we'll be back in 2 minutes with the next session. Thank you.